Uh, Hi, Michael. I hope you are okay.
Yes, please, I am.
Yeah. Do you know if any of your other colleagues will be joining maybe at least one or two so we can start, or is today not a good time for most of you?
Let me text them.
Okay, cool. Thanks. Maybe I'll give it a minute or two to see if any other people will join. If not, then we can start. But in the meantime, let me send a file to you guys about a question, okay? And then where do I? Yeah, I'll send a file to you guys about a question. So in the meantime, you can be going through. You can go through and then let me know what you think the answer is. You can either write it down or just think about it in your head. And then at the end of the lecture, we'll go through and then see whether you have different thoughts about it. So in the meantime, while we are waiting for your colleagues, you can go through, and I'll give it another minute or two, and then we'll start. Okay. I hope the audio is okay. Okay, good. So before we start, is Saturday this time a good time for you? It's just I'm working tomorrow, that's why I brought it here. Or it's Sunday better? Or what do you guys think? I don't know. You can discuss among yourself or in the group. And if you think another day is probably more appropriate, maybe Sundays. If I'm not working, I can do it then. Okay. But I think we can go ahead. Others may join later if they want. So let me start sharing and then we can start this. So we'll be talking about genital arteritis or temporal arteritis today. This will be my outline. Definition, we'll do a case study that I've sent to you. So you can be going through the case study now, but we'll go more into details at the end of the lecture to sort of consolidate what we've learned. We'll talk about the epidemiology, the clinical features, diagnosis, treatment, and then we'll talk just one slide about polymyalgia rheumatica and Takayasu arteritis, just because it's linked with GCA. I don't think we should do a separate lecture for it, but I'll be presenting a lecture in a way such that you don't have to go read them separately, but just link it to GCA in a way, and I'll show you how that can be done, and then a bit of summary at the end. So the case study, as I've sent you, a 68-year-old woman comes to the emergency department with in acute distress, complaining of sudden onset, complete vision in the right eye. It seems he had been having some blurry visions over the last few days, which has worsened in an hour. And she's been having right-sided headaches for about 2 months now, which has not responded to sort of simple analgesia. She has some malaise and fatigue, but it's not vomiting or has no nausea. She's type 2 diabetic, hypertensive, and has some degenerative joint disease. So she's afebrile, blood pressure is okay, heart rate is 78, and examination shows complete loss of vision in the right eye with pupils. About it. Yeah. Examination shows pupils were if not bilaterally, but there was a swollen pale disc with blurred margins. The heartbeat was regular, and there was some bruise in the right subclavian area. Motor and sensory examinations were normal. ESR was raised at 85. What's the most appropriate next step in the management of this patient? So the file that I sent earlier contained the question. You can go to the question. No need to type the answer. You can sort of think about it or write it down. We'll go through at the end later after the lecture, okay? So that's dilatation and swelling of one of the branches of the temporal arteries. So genital arteritis, let me tell you a bit about how the name has come about. And then there's a common misconception. I know most of you may know, but just as a reminder, it's temporal arteritis. So inflammation of the arteries, right? Not arthritis, as in like rheumatoid arthritis. So the spelling is actually also different as well, if you notice. And genital are basically the cells that you see when you do a temporal artery biopsy. We'll go to that in the pathophysiology, okay? And again, this is important. You know, mostly the vasculitis in rheumatology is deemed to be a very complex topic, right? I'll try and give you this baseline so you have a framework in mind when dealing with this clinically and in the exam, all right? So normally it's grouped into three according to the sizes of the vessels, right? So small vessel vasculitis, medium vessel vasculitis, and then large vessel vasculitis. And genital arteritis is part of the large vessel vasculitis. This framework is very important to sort of understand this topic and then to talk about the Takayasu arteritis and the polymyalgia rheumatica as well. Okay, so any vasculitis that you have at all, especially in the rheumatology, think about it as, is it affecting the small vessels? Is it affecting the medium vessels? Is it affecting the medium vessels or is it affecting the large vessels? Obviously, in clinical practice, it's not as clear-cut as that, but in approaching your patients in clinical practice and in the exam, this framework is very important, okay? So for the purposes of exam and this lecture, look at GCA, genital arteritis, as an inflammation of the large vessels. So someone may ask, what are the large vessels, what are the medium vessels, what are the small vessels, right? So basically the small vessels are the little vessels, right, which you can only see microscopically. So you can't see sort of with the naked eye, right? And the medium vessels are like vessels which sort of are the pass-through organs. So for example, the renal artery, right, things like that. And then the large vessels are the aorta mainly and its branches, okay? So that's a good framework to have, and I want you guys to really keep that in mind, okay? So inflammation of the arteries will lead to luminal occlusion, will lead to some ischemic changes, and in some cases with the aorta, it can even lead to aneurysms and dissections later on, okay? Genital arteritis mostly affects the external carotid. Arteritis can affect any of the large vessels, but it mostly affects the external carotid arteries and its branches, the subclavian arteries, the common carotid arteries, and the vertebral arteries and the aorta. So basically, that's the framework of the arteries that it affects. So the carotid arteries, the occipital arteries, temporal arteries, ophthalmic arteries, facial arteries, lingual arteries. So this is very important. If you have, I think someone is not muted. If you have this artery, this scheme in mind, you can sort of deduce the clinical features that you can even have temporal arteritis or genital arteritis, isn't it? Can you guys tell your colleague to sort of mute or something?
Friday. Friday.
Okay, I think I can mute it. Okay. So, for example, if you have an inflammation of the arteries in the occipital region here, sometimes it can lead to blindness, right? Sometimes it can also lead to headache, which occurs at the sort of occipital and temporal region, which is one of the features of genital arteritis. When you have inflammation of the ophthalmic arteries here, for example, again, it can lead to blindness. When you have inflammation of the facial arteries here, so you can lead to people having what we call jaw and tongue claudication, which we'll come to, and then with the carotid arteries as well. So even though it doesn't mostly cause inflammation of the internal carotid arteries, as we just talked about, sometimes it can do, and that can lead to strokes as well. So you may have somebody just with some raised ESR in clinical practice, you have somebody with raised ESR, and then sort of a stroke. And the cause of that may be genital arteritis, all right? So it's the commonest vasculitis, has a prevalence rate of 18 per 100,000 people. And it's mostly found in the Caucasians, so Northern Europe, North America, and it's rarely found in Africa, but lowest prevalence in Asians, African Americans, but in Africa rarely. I didn't find data when I was preparing the slides as well. And it's a predominantly, again, female disease, as with most autoimmune diseases, in a ratio of 2 or 3:1. And the biggest factor is age. So in somebody who is 50 years old, you would almost always never find GCA. So if somebody has even very classical symptoms of GCA, but the person is less than 50, it's very unlikely, right? So it's sort of, the prevalence and incidence sort of starts going up the higher you go. So it starts at 1.5 in the 6th decade, and then by the 8th decade, so in the 80, 90 years old, it's as high as 20 per 100,000 people. And then there's a strong relationship between polymyalgia rheumatica and GCA, where 45% or almost half of patients with GCA will have polymyalgia-like symptoms. So those are symptoms like pain and stiffness in the shoulders, in the hips and the thighs, which is worse in the morning, gets better as the day goes on, all right? And then about 10 to 15% of patients with PMR will go on to develop GCA. So pathophysiology, how does genital arthritis come about? As we've talked about mostly in all our rheumatology lectures, so genetic susceptibility, in terms of GCA, it's HLA-DRB4 and then DRB1. So it's good to know that it's not sort of a question that they really ask, because this can be found in sort of other diseases as well. So it's not very specific for GCA, but there's a genetic link. And then, as you know, with autoimmune diseases, there'll be genetic susceptibility, then there'll be an infectious or environmental trigger, and then the immune system will be set off, right? So infectious triggers have been sort of identified in some cases, even though there's still debate about it. There's nothing conclusive I found on systematic reviews. So para-influenza, mycoplasma, and chlamydia have been known to trigger cases of GCA, but again, as I said, different papers refuted that. But basically, genetics, infectious trigger, and then an immune trigger will come up, right? So what happens? So whatever the immune trigger is, whether it's an infection, whether it's something environmental, it will cause activation and maturation of dendritic cells, which will then lead to T cell activation. And these T cells will also sort of release cytokines, interleukin 6, interleukin 17, interferon gamma. And these cytokines will lead to sort of activation and recruitment of neutrophils and especially macrophages. And then it's the coming together, right? Coming together of these macrophages with sort of different nuclei that forms the complex that we call giant cells. So they look under the microscope. When you take a biopsy and look under the microscope, they look like giant cells, which is basically a collection of these macrophages. And that's where the name came about. Yeah, so take this to be these are the layers of a vessel, right? So the various layers, the innermost layer will be the intima, isn't it? And then you have the media, and then you have the adventitia outside, right? So there'll be immune activation, which mostly takes place in the adventitia, which I said will lead to maturation of dendritic cells, which will then lead to production of T helper cells, cytokines, interleukin 1, interleukin 6, interleukin 17, and then also interferon gamma. And this will lead to proliferation of macrophages and neutrophils, which will form these multinucleated giant cells. So that is where the name genital arthritis comes from. And then this will obviously release nitric oxide, some proteases, which will lead to sort of breakdown of the intima. And then you have narrowing of the lumen as proliferation goes on. And sometimes you can have sort of new vascularization, that is new sort of intima layer forming within the vessel as well, which will lead to narrowing of the vessels. And this is what will bring about your sort of symptoms, right? Yeah, so this is a nice scheme for it. So dendritic cells, interleukin 6, interleukin 12, 18, CD4 cells. They will form T helper 17 cells, T helper 1 cells. This will also form interferon gamma. This will lead to formation of macrophages. And it's this giant cells formed collection of these macrophages, so several macrophages here, which will then go into the layer between the between the middle layer and the intima, right? So within the tunica media and the intima, and this will lead to mural weakening, hyperplasia, stenosis, so narrowing of the lumen, and sometimes new lumens being formed within a lumen already. Obviously, this will lead to stenosis, and this will bring about your symptoms of GCA depending on the arteries affected. So we talked about large vessel vasculitis. Remember how I said you should look at vasculitis, even though it's complex, look at it as small vessel vasculitis, medium vessel, and then large vessel. So with GCA, as I said, it's a large vessel vasculitis, right? So when we talk about the typical GCA, so you know the one that comes with the headache and all that, so we call it cranial GCA. I just want you to understand this scheme because when you know just GCA, it can help you extrapolate, and then you don't need to learn Takayasu arteritis separately, right? So the dark parts are the main arteries which are affected. So these are the obviously the outer and its branches into the head and all that, right? So GCA will mostly affect the arteries in the head, as we talked about, external carotid arteries, occipital, temporal arteries, and then sometimes you can have people who have large vessel vasculitis, but they wouldn't have sort of these cranial symptoms. So those people can be termed as large vessel vasculitis, right? And then you have what we call Takayasu arteritis, which mostly forms in the subclavian, the carotid, so mostly the internal carotid, compared to GCA itself, which is the external carotid. In Takayasu arteritis, you have it in younger females, right? So between the ages of 20 to 40. Remember, we said GCA is prevalent in the elderly population. But with Takayasu arteritis, it's more in the younger people, so adolescents and young girls between the ages of 20 to 40 who come with, so they can come with claudication in the arms, because normally, we see where my arrow is, normally the subclavian arteries or sort of the common carotid arteries, especially the internal carotid arteries, which can lead to sort of carotid dissections, which can lead to strokes and all that. So that's how Takayasu presents. So as I said, this is all like a spectrum, right? With large vessel vasculitis, it's the aorta itself that's affected. So you have somebody with, let's say, just constitutional symptoms, some fever of unknown origin, no one is sure where it is. You go and do a PET scan, and then you see the aorta is inflamed. It's inflamed. That's what we call large vessel vasculitis. And then with GCA, is when it's affecting the head, the vessels of the head and face. And then with Takayasu arteritis, that's when it's affecting sort of the branches of the aortic arch, so the subclavian and the internal carotid arteries, okay, in a younger female. So this is a very good framework to have for large vessel vasculitis. So what are the clinical features of GCA? So I want you to look at it in four folds. What happens to the head or the arteries in the head and the ocular symptoms, right? So you have headache, which normally is not responding to analgesia. So somebody has come with headache for like a month ago, an elderly person, 80-year-old, is having headache, she's having some scalp tenderness. She says, oh, doctor, I'm not able to comb my hair because when I'm combing my hair, it's painful. When I'm wearing hats, it's painful. Or when I touch my scalp, especially in the temporal region on the side, it's painful. You should be thinking about genital arthritis. And then when either the facial or lingual arteries are involved, you can have what we call jaw or tongue claudication, which is also a very common feature of genital arthritis. So jaw claudication is like, remember if you have peripheral vascular disease, right? And then somebody has limb claudication, where they are walking, they walk maybe 100 meters, then they have to stop for the blood flow to sort of go into the legs to improve the pain. It's the same with jaw claudication. So it's not pain that is arrest, but it's pain that sort of when they start chewing. With the first bite, there may not be any pain, but then as they are sort of biting, maybe by the third or fourth bite, they'll start having pains. When they stop, the pain comes down. So that's typical jaw claudication, which obviously will happen when there's any reduced blood flow. Sometimes you can have dysphagia as well. Sometimes you can have changes in your hearing as well, depending on which of the arteries are involved. And then very important, because this is a very serious complication of GCA. So this makes GCA one of the rheumatology emergencies, because it can lead to visual loss, especially when the either branches of the optic nerve are involved, or sometimes even the occipital arteries. It can lead to sort of temporary or even permanent loss of vision. That's why normally when you get such patients, you need to start treating even before you do any investigations to diagnose, okay? So amaurosis fugax, where you have a sudden monocular vision loss, is very common. Before then, as in the case I gave you guys at the beginning. So you remember this lady was having sort of blurring of vision a couple of days, and then in the last few days, the vision sort of went totally. So sometimes it starts with some double vision, and then later some temporary loss of vision to maybe just amaurosis for that, it may come again, and then later it can lead to permanent vision loss. So it's very important to treat any cases of GCA promptly before you even go to diagnose with imaging, which we'll come to. And then the most common finding on ophthalmology review is anterior ischemic optic neuropathy. Again, it's an inflammatory condition, inflammation of the vessels. So you have your typical systemic symptoms, your fever, night sweats, malaise, lethargy, not feeling well, weight loss, and things like that. And then, as I said, the association with PMR. So PMR has been associated with, in 45% of patients, as we said, they will have a PMR, which is basically pain and stiffness in the upper and lower proximal lymph girdles, sorry. So you have pain in the shoulder, in the upper arms, you have some stiffness with it, worse in the morning, and gets better as the day goes on. You find out that patients say they are not able to sort of reach, let's say, things on a shelf, and they are not able to stand up from a sitting position because the hips and the thighs are affected. So most patients with GCA will also have some PMR-like symptoms. And then you remember the scheme I showed you. So it's part of a large vessel vasculitis. So even though it's in the head, when you're evaluating such people in practice, you need to make sure that whatever, let's say, they're having headaches, scalp tenderness, which is an occlusion of the temporal arteries, right? But has any other artery also been involved, or is any other artery in the process of occlusion as well, right? Because any of the branches of the aorta can be affected. So when you are evaluating people for GCA, even though you are looking and focusing on the head, you should be checking for their pulses as well, or whether they have any claudication in the arm, whether when they are trying to sort of lift heavy loads to put on a shelf or something, they are having pain, and then when they rest it stops, or whether they have any sort of radial delays, whether they have absent pulses in one hand, or whether they have any bruits in the neck, subclavian arteries to suggest any sort of reduction of flow, which will mean stenosis of the arteries, all right? And then with a late disease, a late complication is a thoracic artery aneurysms and dissection. So this is very late complication of the disease. It mostly is not treated. So I want you to have this scheme in mind about genital arteritis. So we are talking about it. Again, let me just go over, because I think it's important that you have this scheme in mind. I'll send the slides again after the presentation, but this scheme I want you to have in mind. It will help you deal with any cases with GCA, PMR, Takayasu arteritis, large cell vasculitis. So this is all in one slide, which is very helpful. So with the vascular symptoms in the head, we've talked about it, new onset headache in somebody who is greater than 50 years old, mostly as you age, your risk is higher. You have scalp tenderness, and then you have claudication of the tongue and the jaw, and mostly, as we said, is outer and its branches, so mostly upper more than lower extremities. And the visual complications of it is what we really worry about. So anybody with GCA, you need to really ask, even if they don't say, you need to really ask if they are having any sort of blurred vision or double vision in the last few days. And as we said, the most sort of common finding on ophthalmology assessment is anterior ischemic optic neuropathy. All right, and then you see this swollen pale disc because of reduced blood flow. Sometimes you can have no, Grace, don't worry. I think I muted you. Sometimes you can have central retinal artery occlusions as well, but the most important finding is acute ischemic optic neuropathy. And then we talked about the link with PMR to polymyalgia rheumatica. It's important to ask them whether they've had some stiffness in the joints, the shoulders, the hips, or the thighs in the morning, which is worse as the day goes on. And then constitutional symptoms, again, this is a given for any sort of inflammatory disease, isn't it? Fever, night sweats, and things of that nature. So how do we diagnose GCA? there's no one test that'll give you the answer, as with many rheumatological and even many medical diagnoses. So your clinical history is very important, examination findings, and then laboratory or blood test, and if there's any imaging. So clinical history, we've talked about it. I'm just repeating: headache, new onset, scalp tenderness, elderly person of Caucasian origin. It's very rare in Asians and Blacks, and who comes in with headache, scalp tenderness, some jaw claudication, some systemic symptoms and things like that. And then what are the typical examinations that you may find? You may find that the temporal arteries are tender. They are not pulsating well because of stenosis or reduced blood flow. And as I said, it's very important that we are sure we are not missing a large vessel vasculitis. Even though GCA is just limited to the head, you want to be sure there's nothing else going on in the outer and its other sort of subclavian branches and things like that. So you need to listen, put your stethoscope over the carotid, subclavian, axillary arteries. Maybe you can hear a bruit. You need to check the pulses in both hands, especially any young or any female who comes. And sometimes there'll be blood pressure discrepancies as well. So you need to check the blood pressure in both arms. And obviously your eye examination is very important. And if there's any suggestion of eye symptoms, you need to get an ophthalmology assessment ASAP. So they are sure there's no eye involvement. Because if there are eye involvement, as you see when we get to treatment, the treatment will be different, okay? And then when you come to the blood test, so obviously your full blood count, ESR, inflammatory markers. So nothing basically specific, but normally ESR greater than 50, CRP greater than 30, you should be thinking about genital arteritis if the person has a headache. Normally ESR, they say sort of rises first, but CRP can be more sensitive. And if you started somebody on treatment already and you want to see their response to treatment, you may want to look at the CRP trend rather than the ESR, okay? And then because it's an inflammatory condition, you may have some anemia of chronic disease, you may have some thrombocytosis, which will be sort of just a marker of inflammation. And the diagnosis, you diagnose by temporal artery biopsy, which is the gold standard, okay? Obviously, you go there, you take your biopsy, you look at it under the microscope, and it will be, if you see the germ cells that we talked about in the pathophysiology, then you have your diagnosis. So it's when you have that diagnosis, it's 100% specific that it is, but there are what we call skip lesions. So how the inflammation happens, it doesn't happen along the whole length of the arteries. So you may have some patchy bits where there are sort of inflammation going on, and then you may have a bit or part of the temporal arteries which are not inflamed. So sometimes you may take a part of the temporal artery for biopsy, which is not where the inflammation is going on, right? So it's not sensitive that way. So you can actually do a biopsy and miss it because you've not taken the right sample, all right? So because of that, now ultrasound is very widespread. Before even patients go for a temporal artery biopsy, we are now using ultrasound more. But obviously, it's not as widespread. You need really expertise with it because it's sort of a different kind of imaging, not something that your regular radiologist will be able to do. So it's still not done everywhere, but just know about it that it's used. But for the purposes of exam and as of now, temporal artery biopsies are the gold standard. And then remember we said, because of the various complications that can come in, especially things like blindness, which can be permanent, and things like stroke as well, if rarely the internal carotids are affected, you should start treatment as soon as you suspect genital arteritis. So don't wait at all. Obviously, you can maybe take some quick blood, but then start your treatment straight away. Your treatment will be steroids, we'll come to it later, but start your steroids as soon as possible before you even send the patient for either temporal artery biopsy or do an ultrasound, all right? Just to prevent the visual loss. And you remember I told you when you are assessing, you should look at the other vessels to see whether they have also been affected. So you may be thinking about things like angiograms or angiographies to see whether or any branches of the aorta itself is also affected. In case you have any suspicion for it, maybe somebody has come with headache, some scalp tenderness, jaw claudication, and then you are checking the pulses and you see that there's one pulse is absent, on the, let's say, on the left or something. So you'll be thinking about, oh, even though this is a cranial genital arteritis, has it gone on to involve the aorta and its other branches? So you may want to do angiograms to look at the whole vessels, to look whether there's stenosis or anything like that anywhere. And sometimes you can do a PET scan. This is very important in people who come with more constitutional symptoms. So feeling unwell, fever, raised CRP. So normally fever of unknown origin. And then nobody's really sure where it is, but the patient has some headaches, maybe some scalp tenderness. We are not sure. You may, even after doing a temporal artery biopsy, which is negative, you may consider something like a PET scan to see whether there's uptake anywhere along the vessels, which may point to one of the large vessels being inflamed. Okay. And then when you are thinking of things like dissection and aneurysms, you may want to do a sort of a CT of the aortic arch or the major branches to rule out dissection or aneurysms, especially in advanced disease, where let's say somebody comes in with back pain, has some systemic symptoms and things like that. So this is what you see in the temporal artery biopsy. So you remember the layers of the vessels that we just talked about. So this is the tunica adventitia, which is sort of the muscular outer layer. This is the tunica media, and then this is the tunica intima, right? And then you can see here, so this nice sort of lumen here. So this is a lumen that our blood can flow through. But see in genital arthritis here, right? Where you have so you have your adventitia on the outside, you have the media here, and then you have, if you can see my outline, so you have the intima somewhere here. But then you can see that just around this again, there's been another intima form. So you remember when we're talking about the pathogenesis, that after you form these germ cells, which are made up of macrophages, even though they cause inflammation, sometimes they can cause sort of new vascularization or new intima formation. So there's another sort of intima or layer in the inner layer, which will lead to very much narrowing of the lumen here. So obviously, blood flow will be reduced here, and this will lead to other symptoms of GCA. And then, so this is what we call the halo sign as well, normally with the ultrasound. As I said, it's now being commonly used here. And so again, this is the lumen, and this is the intima, right? So this is the inner layer of the vessel. Notice this raised here. So probably there may be another new intima here, but you can see it's sort of thicker than a normal one here. And then you have sort of the lumen here, which is narrowed. And this sign is what we call the halo sign, and it's sort of typical for genital arthritis when using ultrasound. So treatment is with steroids. And I want you to look at the treatment in this way. So you start steroids as soon as possible when you think of GCA, right? You start 1 milligram per kg. So if the patient is 60 kilogram, you start, if the patient is 60 kg, you start 60 milligram of steroids. Okay, and as I said, this is to prevent the ocular manifestations even before you get your temporal artery biopsy done. And then, because this inflammation, normally GCA presents insidiously. So the person may be having headaches for like, let's say 2-3 months, and then it's worsened or the scalp tenderness has come maybe in the last 1 week or something. So it's normally a disease which has gone on for some time. So we treat normally over a year to 2 years. So normally we do them steroids 60 milligrams for like 1 month. And then when the symptoms have resolved, the blood tests have come down, we advise them to go down gradually. So they come off steroids hopefully within a year or 2 years, mostly to prevent relapse. Okay. And steroids really help with GCA. So if you are treating somebody with GCA, you've given them the steroids for like a week, and they say their headache is still ongoing. You need to reevaluate your diagnosis because they really respond well to steroids. And we use IV steroids if there are visual complications. So the Zoom is about to end. So we'll log back in and then talk about the treatment and complications, and then we'll do with a question at the beginning, okay? And then I'll take any questions or if you want me to clarify anything.